As requested, I'm going to do some tutoring over your chapter titled Thyroid and Parathyroid Disorders. Here I have the objectives of the chapters. I have another page. If you want to read through those, you can pause the recording, but I'm going to go on and get right to it. So the thyroid gland is located in the neck. It's kind of shaped like a bow tie, and on the back of it there's, if you can imagine, 4 big polka dots, and those 4 big polka dots are the parathyroid. And so we'll be talking about disorders of both. Basically, we can break it down into 4 things. So if you imagine a square with an X in the middle of it, so we have 4 sections. And top half is thyroid, bottom half is parathyroid. So thyroid, we can have 2 basic things go wrong. We can have too much, or hyperthyroid, and then we can have too little, which is hypothyroid. And then same thing with the parathyroid. We can have either too much, so hyperparathyroidism, or hypoparathyroidism. When those 2 go together is when we get into things like surgery. So if we did surgery because someone had a hyperthyroidism, maybe they have a tumor on their thyroid, and maybe we're not such a great surgeon, we go in trying to take the thyroid out, and inadvertently we take the parathyroid out too. So that's what their relationship with each other is sometimes what you do to the one, you do to the other, because they're actually kind of attached to each other. They are capable of being separated. A skilled surgeon can remove the thyroid gland without removing the parathyroid, kind of carefully cut those out, or vice versa, can remove the parathyroid without necessarily destroying the whole thyroid. But because they are an organ they're kind of stuck together, often they're going to go together. So types of thyroid, we'll start with the thyroid. We have hyperactive thyroid. This is sometimes called Graves' disease. And then an underactive thyroid is just called hypothyroidism, or sometimes it's called myxedema. Signs and symptoms are going to be mostly opposites on these 2. And so to differentiate, I'm going to think of those with Graves' disease as zombies, and I just get that from the, no offense to people who have a hyperactive thyroid, but when you see the word Graves, it reminds me of zombies coming out of the grave. So I'm going to use a zombie analogy here with my Graves' disease. So with hyperthyroidism or Graves' disease, increased activity. So 2 hormones that are produced by the thyroid gland are the T3 and T4. Now don't get confused about that TSH that we talked about previously in the pituitary chapter. TSH stands for thyroid stimulating hormone. It's produced by the pituitary gland. Reminder, pituitary gland doesn't really do anything itself. It just bosses people around, tells other people what to do. So TSH is produced by the pituitary thyroid stimulating hormone. It travels to the thyroid and then makes the thyroid get to work. So sometimes overproduction of T3 and T4 kind of uses up all of that TSH. So when we're looking at blood or serum levels, usually they're going to be opposite. So if you have too much T3 and T4, you're going to have too little TSH, because the thyroid's used up all of that thyroid stimulating hormone. And the opposite can be true. Maybe we have plenty of thyroid stimulating hormone, but we have this lazy old thyroid that won't use it. So we have high serum TSH, but low serum T3 and T4. So just know that even though they all seem like thyroid labs, they're going to be opposite of each other usually. So high TSH is going to result in low T3 and T4. But in this case, we have high T3 and T4, particularly the T3 with Graves' disease, and we're going to have lowered levels of TSH because they've gobbled it all up. And so what happens is the metabolic processes are exaggerated. So zombies should be motionless. They're dead, right? But they just keep going and going without getting tired. So that illustrates the metabolic processes are exaggerated. So hypermetabolism. It does occur in women more than men, and of course women naturally make better zombies, right? Age 30 to 50, ooh, that's me. I'd make a pretty good zombie. Other manifestations: anterior neck edema, and that has to do with the fact that the thyroid's located in the neck, and so it's going to be swollen. Overactive, that makes sense. Bulging eyeballs, that's kind of weird, but here you can see my zombie has a bulging eyeball. This is sometimes called periorbital edema, and it gives a kind of a startled or scary appearance to the person. Dysphagia, again, we see GI here, so we're talking about difficulty swallowing or hoarseness, and again, that has to do with the fact that it's location right here in the throat, so it can put pressure on the larynx and cause hoarseness, or pressure on the pharynx and cause dysphagia, or even the esophagus. Weight loss, even with good appetite for human flesh, right? But no, everything's hyper mode, so hypermetabolism, so they can eat plenty of food but still be losing weight. Nervous, jittery, excitable, that's exactly what this guy looks like here. Weakness, insomnia, so inability to sleep. The dead never sleep, right? Although being tired, wishing they could sleep. And then a family history, so this is often hereditary. It's passed on from parent to child. Other manifestations, everything is going to increase, so be thinking hyper. So all of your vital signs increase. Your blood pressure goes up, your temperature goes up, your pulse goes up. And so I have a fan here because hyperthyroid people are usually hot. They're just constantly hot. So I have intolerance to heat down here. You may hear bruise over the thyroid. That's that whooshing sound of the blood. Skin is going to be warm and flushed. Diaphoresis or sweating, shortness of breath, elevated respiratory rate, tremors. Hair becomes fine and soft, kind of like a baby's. Menstruation may cease, and then hyperactivity and clumsiness. So picture a zombie walk, and that's what we're talking about with the clumsiness. And I know lab values aren't very much fun to talk about, but we really do need to talk about those. I told you the elevated T3 especially, but probably elevations of both T3 and T4 are going to be diagnostic of hyper. Let me pull the screen up a little bit here. Another important thing to know about the thyroid is that it has a pretty good relationship with iodine. It requires iodine to work. And so one of the tests that we can do is a thyroid scan or a thyroid uptake. And both of those use radioactive iodine. And so we can see how much radioactive iodine the thyroid's gobbling up. It gobbles it up because it's iodine. We just kind of piggyback the radioactive part to it so that we can see it. It'll light up when we look at it under a scintillator. And if you're wondering what the heck is a scintillator, it sounds like something that would be like an air freshener. No, it's a material that fluoresces when struck by a charged particle or high energy photon. So these pretty things right here would be examples of scintillators, so they light up. So we're going to administer radioactive iodine. Thyroid's going to gobble it up, and then we can tell by how fast it gobbles it up. So this is called a thyroid scan. And then it will send us images. So I have a picture of an image. So here's the process. You take a radioactive iodine pill, and then we wait a little bit, and then we do the little gamma probe running over the thyroid gland. And so here would be an example. So normal thyroid uptake, it gobbled up a little bit of it. Graves' disease, it was voracious. It's a zombie ready to devour everything that it comes in contact with. So you can see huge amounts of the iodine gobbled up here. So you might be thinking, since we're on zombies and graves, and I had Dracula there ready to draw the blood, and you might be thinking, okay, when we're dealing with radioactive stuff, that's kind of scary. If I'm the nurse, am I going to be exposed to radiation? And that's a legitimate question, but the answer is not really. They are going to clear this out of their urine. So really the big radioactive precaution to take is just being careful with pee. So if you're the nurse and you have to come in contact with pee, you might, double glove, maybe double flush. And certainly use soap and water we're not dealing with chemical warfare here. So making sure you wash your hands thoroughly with soap and water to get anything that might have gotten on there. That's really the best precaution that you and the patient need to take. And so this really isn't that dangerous of a thing, even though it sounds dangerous to be dealing with. Nursing interventions are really just related to the symptoms. So if you're following along on page 1042, the first intervention it addresses is decreased cardiac output. That usually means low or blood pressure issues. And so we're going to monitor pulse and blood pressure and respiratory rate as well, temperature, because again they're going to get too hot. Disturbed sleep pattern, which I have over here. Encourage bedtime rituals, avoid stimulants, and that goes for pretty much all day because they're already overstimulated, hypermetabolism, so avoiding stimulants all day and especially at night. Here I have changed the sheets. That's hyperthermia is going to make them sweat a lot, so making sure that we keep their bed dry from all of their diaphoresis. Weights, daily weights, because they're going to be high risk for weight loss. Imbalanced nutrition, less than body requirements, so we got to increase calories. I would like to do this one day, I think, and just one day, then I don't want to have thyroid surgery. But yeah, 4,000 to 5,000 calories a day might be necessary to keep them from losing weight. And then they're going to be at risk for injury due to that those swollen eyes. You can, if the patient's worried about it and they say, oh my gosh, is my eyeball going to be bulging out forever? The answer is no. The condition usually goes away after treatment for the hyperparathyroidism, or hyperthyroidism. If it doesn't, then there are some surgical procedures that can be done. But whatever the case, you can reassure the patient we're going to get it fixed. It will either go away or we'll do surgery to fix it, but they are not going to have this bulging eyeball forever. And in the meantime, we just have to be careful of those eyes. It may be necessary to tape the lids shut temporarily. Artificial tears would be very helpful. So what can we do about it? We can attack it with radiation, or we can attack it with medication, or we can do surgical management, which seems to be one of the more common. So surgical management, we can either take the entire thyroid out if that's causing the problem, or a preferred would be a subtotal thyroidectomy. So we can remove up to 5/6 of it and leave 1/6, so it can still do its job. It can still pump out T3 and T4, just maybe not in the amounts that it's been. And so this would probably be one of the better choices, because if we take the entire thyroid out, which I have right here, what do you think patients will need long-term post-op? Well, yeah, they're going to need synthetic thyroid medication, or Synthroid, for the rest of their life. But sometimes if we can just leave a little tiny bit of it, since it's an overactive little critter, leaving just 1/6 of it, and that will be sufficient. They won't have to take the medicine. However, if we do that during surgery, we have to watch out for something that's called thyroid storm, and that's hyperthyroidism on steroids. So thyroid storm, dangerous tachycardia and hyperthermia, and that can sometimes happen with this one little bitty 1/5 because he thinks he has to make up for all of the rest. So that would be one. Post-op intervention is watching for thyroid storm if it's not a total, if it's subtotal, which is again shown right here. Here's a video that is going to show the surgery if you want. It's kind of grody, but interesting nonetheless. Post-op, support the head. We want them in this semi-Fowler's position to promote if there's any drainage, and we're really worried about the airway closing off, because anytime you cut on somebody, they're going to swell, right? So we're going to keep a suction and trach set nearby just in case they start having trouble breathing. We can intubate them quickly. We hope that doesn't happen, but we want to be able to do it fast if it does. Humidifier, again, to make it a little bit easier to breathe, and monitoring for that difficulty breathing. Bleeding, where might it hide? It can run back here behind the neck and run down the back, so make sure you're not just looking right here at the front and, oh, they're not bleeding, and then in the meantime they have like 2 gallons of blood pooling behind here. Also, it's close to the larynx, and so we can run into trouble of accidentally nicking the vocal cords, and in that case they wouldn't be able to talk. So voice checks every 2 to 4 hours, if not contraindicated, is a way that we check and see if the larynx was damaged during surgery.